Hey everyone, welcome to Pediatime, Time to Learn Pediatrics. In this video, we're discussing Angelman Syndrome, a genetic neurodevelopmental disorder that every pediatrician and medical student should recognize. Let's break it down into 5 essential points. First, the genetics. Angelman syndrome results from loss of function of the maternal UBE3A gene located on chromosome 15q11 to 13. The majority of cases, about 70%, occur due to maternal deletion. Other mechanisms include paternal uniparental disomy in 7%, imprinting defects in 3%, and UBE3A mutations in 11% of cases. This is a classic example of genomic imprinting, where the paternal copy is normally silenced in neurons, making the maternal copy essential for normal neurological development. Second, the clinical presentation. These children have a characteristic triad: severe developmental delay with absent or minimal speech, a movement disorder featuring ataxic gait and tremulous limb movements, and the distinctive behavioral phenotype. The behavior is actually quite recognizable: frequent laughter and smiling, a happy demeanor, excitability, and hand-flapping stereotypies. This combination of features often leads to the initial clinical suspicion. Third, neurological manifestations. Seizures develop in 80 to 90% of patients, typically with onset before age 3. The EEG often shows a characteristic pattern with high-amplitude rhythmic activity at 2 to 3 Hz. Microcephaly develops in about 80% by age 2, and sleep disturbances are nearly universal, affecting quality of life for both patients and families significantly. Fourth, making the diagnosis. While clinical features raise suspicion, diagnosis is confirmed through genetic testing. Methylation analysis is the first-line test, detecting about 80% of cases. UBE3A gene sequencing identifies additional cases. Think of Angelman syndrome in any child presenting with unexplained developmental delay, absent speech, happy affect, and ataxia. An important differential is Prader-Willi syndrome, which involves the same genetic region but with paternal deletion and a completely different phenotype. Finally, management. Currently, there's no disease-modifying therapy, so treatment is supportive and multidisciplinary. Seizures are managed with antiepileptics like valproate, levetiracetam, or clonazepam. Physical and occupational therapy help with motor development. Speech therapy combined with augmentative and alternative communication devices can significantly improve quality of life. Melatonin helps with sleep disturbances, and behavioral interventions address challenging behaviors. The good news is that with appropriate supportive care, life expectancy is near normal. And that's Angelman syndrome in 5 key points. If you found this helpful, please subscribe to Pediatime for more focused pediatric learning. Hit the bell icon so you never miss an update. What topics should we cover next? Let me know in the comments. Until next time, keep learning.